صباح الخير أو مساء الخير. النهاردة أنا دكتور عزة عرابي. My talk today is about stroke in childhood. And first of all, let's define stroke. It is the sudden interruption of blood supply to the brain because of occlusion or rupture of cerebral arteries or veins. And this results in cerebral damage together with a clinical neurological deficits. Stroke should always be considered in any child presenting with an acute onset of focal neurological deficits. And this is very important because it's not a rare condition, and the early management is crucial in the outcome of. So as I mentioned, childhood stroke is not common, is not rare, and it's in the developed countries, it is considered one of the top 10 causes of death in children, while it accounts for at least 25% of strokes occurring below the age of 40. So how frequent it is? In the newborn, stroke occurs in 1 in about 3,000 live-born children, while during childhood, the incidence is 2 to 3 per 100,000 child per year. Hemorrhagic stroke and ischemic stroke are almost equally distributed, with the hemorrhagic stroke being either intracranial hemorrhage or subarachnoid hemorrhage. The intracranial hemorrhage is more common than the subarachnoid, accounting for about 0.8 per 100,000, while the subarachnoid 0.3 per 100,000 children. So as I mentioned, it's very important to identify it early in order to reach a better outcome. Outcome of stroke is generally better in children than in adults. And this is for two reasons. First of all, the brain plasticity, which is a characteristic of childhood brains, and this is the ability to reorganize networks within the brain. This is also supported by the fact the brain is still developing, so during the development there is a more chance for reorganization of the networks. A risk factor for arterial ischemic disease is almost present in half of children at the time of the episode. The common risk factors in children include congenital heart disease, sickle cell disease, infections, and various hypercoagulable states. The most common identifiable cause of stroke in children is probably heart disease, and it is documented in at least 19% of children with arterial thrombosis. Recent studies underline the importance of infections as a risk factor for for stroke in children, and it seems that at least a third of cases of childhood stroke occur in such a context. However, these percentages has always been hampered by the fact that viral infections are generally common in children. The number I mentioned, this 1/3, is before the COVID era, and of course many things are going to change after COVID-19. A fifth of the children with ischemic infarction of unknown origin have a history of prior chickenpox within the past 12 months. 12 months is quite a long period, but this has been an association and a finding, and it's worth mentioning. In arterial ischemic stroke, arterial occlusion results usually from thromboembolism and results in focal infarction within the specific arterial territory. In symptomatic synovenous thrombosis, Cerebral veins and or dural venous sinuses may be thrombosed, but may or may not result in parenchymal venous infarction. Hemorrhagic strokes are classified primarily by their intracranial location, whether intracerebral or subarachnoid. An overlap occurs between ischemic and hemorrhagic strokes under certain circumstances, where hemorrhagic transformation takes place after an initial ischemic infarct. And of course, this is a very characteristic event that can happen in newborn children in particular, where we have hemorrhage following an ischemia in cases of hypoxic ischemic encephalopathy. The vascular patterns of acute arterial ischemic stroke can be classified according to the size of the vessel. It can be a large or small vessel infarct. Infarctions due to occlusion of large caliber cerebral arteries usually result in a characteristic peripheral wedge-shaped lesions involving the cerebral cortex and the adjacent white matter in the characteristic anatomical distribution of this particular artery. Venous strokes typically occur in areas where there is adjacent to the venous sinuses and result from locally increased venous pressure as a result of the thrombosis, which impedes the arterial flow and may result in local hemorrhages. So the venous occlusion impedes the arterial flow because of increasing the pressure, and may result in a local hemorrhage and venous infarcts. And this slide shows the cerebral arteries with the basilar artery and the two internal carotids and circle of Willis and all the blood supply of the brain. The following slide shows the lateral aspect of the brain and how the arterial supply is distributed. The orange area, which is a major part here, is supplied by the middle cerebral artery, while the yellow one by the anterior and the blue by the posterior. This slide shows the medial aspect of the brain, and the major part here is supplied by the anterior cerebral artery, with the posterior portion by the posterior cerebral artery. The next slide shows the anatomical distribution of the human body in relation to the motor cortical area and the relative proportions of each part of the body in relation to the amount of cortical neural supply. In this slide, we have a look at the tutorial distribution of the different cerebral artery and the clinical presentation of their occlusion. In the internal carotid arteries, we get hemiparesis, aphasia, and hemianopia. In the anterior and the middle cerebral arteries, we get hemiparesis, but in the anterior cerebral artery, it is more predominantly affecting the leg, while in the middle cerebral artery, it affects more the upper limbs. And in the middle cerebral artery, we get hemianopia and aphasia as well. In the posterior cerebral artery occlusion, there is hemianopia, ataxia, cranial nerve affection, a mild hemiparesis, and dizziness. While the basilar artery, the presentation is mainly of brain stem and cerebellar affection with breathing, sensory, and balance disturbances, ataxia, nystagmus, tremor, and vomiting. The cerebellar artery occlusions result in sensory disturbances, headache, fever, vomiting, and cerebellar signs. The next slide. This slide shows the middle cerebral artery and its proximal part with the lenticulostriate branches. and its distal part dividing into the anterior and posterior branches with the frontal and frontal and temporal and parietal branches. Most arterial ischemic strokes involve the middle cerebral artery. It's by far the most common. It occurs in recognizable patterns according to the middle cerebral artery territory occlusion. This includes proximal occlusion that results in entire infarction of the entire area supplied by the middle cerebral artery, or distal occlusion, and in this case the basal ganglia is spared because lenticulostriate branches take place in the proximal portion, and or anterior or posterior branch occlusion, which can be frontal or parietal and temporal respectively according to the branch. Or finally, it can be lenticulostriate only, and this results in basal ganglia and deep white matter infarction. Lenticulostriate arteries are end arteries, as mentioned, and they lack collaterals, conferring a higher risk of permanent infarction. The other branches can have collaterals, but the lenticulostriates do not develop and do not have collaterals, and that's why a higher risk for permanent damage is present when there is occlusion of the lenticulostriate branches in particular. Despite being small, the area supplied by the lenticulostriate branches contain critical structures and functional tracts such as the internal capsule. Isolated lenticulostriate artery occlusion is commonly associated with para-infectious or inflammatory arteriopathy etiologies. And in population-based studies, those small vessel distribution infarction account for at least 50% of childhood ischemic strokes. And for unknown reasons, these usually affect the left hemisphere more common. The affection of the left hemisphere is more common than the right hemisphere. Basilar artery thrombosis can be a life-threatening condition, and often combining multiple infarcts involving brainstem perforators, cerebellar branches, and posterior cerebral artery. Cervical arteries are a frequent site for arterial dissection, and it causes infarction primarily via artery-to-artery emboli. Then we come to the low-flow infarcts. Ischemic lesions caused by diffuse hypoperfusion occur typically in watershed zones at the anterior, middle, and or posterior cerebral artery junctions. So at the area where supply of different arteries meet, these are watershed zones, and hypoperfusion infarcts usually occur in these areas. Although typically it should, theoretically and typically they do occur bilaterally, however, sometimes the affection may be asymmetrical or unilateral. And in the setting of proximal arterial stenosis or occlusion, as in moya, low-flow infarcts also appear in distal arterial zones, typically periventricular white matter. This is the internal capsule, and it's typically supplied by more than one source of blood supply, except for the genu, which is supplied only from the lenticulostriate branches of the middle cerebral artery. The posterior limb is supplied as well by the anterior choroid branches from the anterior choroid artery, which originates from the internal carotid, while the anterior limb is receives supply also from subcortical structures. So, if we have a patient with hemiparesis, how can we tell if it is a small internal capsule stroke or a bigger anterior or middle cerebral artery cortical stroke? How can you tell whether the stroke is cortical or subcortical? And what are the symptoms, other symptoms and signs that can help you localize this? The injury to the cortex produces symptoms and signs that are not commonly produced by injury to subcortical areas. These include seizures, expressive or receptive aphasia, and visual field deficits. These are not present when there is a capsular stroke. So if it is a small internal capsule, you wouldn't expect the presence of seizures, expressive or receptive aphasia, or visual problems. The pathogenesis of ischemic strokes. Generally speaking, thrombosis is a product of coagulation and platelet hemostatic systems. In situations of blood stasis or slow flow, such as in the venous system, the coagulation system predominates, resulting in fibrin-rich thrombi. However, in arteries, platelet activation with platelet-rich thrombi is a significant contributor to thrombus formation, combining with the coagulation activation. The balance of which system predominates varies with flow rate, shear stresses, endothelial integrity, and concentrations of circulating anticoagulants. In arterial ischemic strokes, the severity of cerebral tissue damage and neurological impairments are a function of multiple factors. These include the duration of ischemia and timing of perfusion restoration, the availability of collateral arterial blood supply, volume and functional components of structures affected, the maturational status of the brain, and the concurrent disease processes and the metabolic demands of the ischemic brain tissue. Ischemic neuronal dysfunction can be reversible initially, but with shift to irreversible infarction, this occurs with increasing duration or increasing severity of ischemia or the metabolic demand and neuronal activity. In a transient ischemic attack, there is no permanent parenchymal lesion seen on MRI, and this is consistent with the transient symptomatology, which usually resolve within 60 minutes. While in acute arterial ischemic strokes, a marked decrease in focal cerebral perfusion results in a central area or core zone of irreversible brain damage, and a surrounding area of less severely compromised or penumbral zone where tissues is partially injured, but however it remains potentially viable, and depending on how fast we act, the fate of this penumbral zone will be affected. So in the penumbra, clinical factors that increase the discrepancy between cerebral metabolic rate and delivery of oxygen and glucose result in additional tissue injury and cell death. Secondary insults, including seizures and alterations in temperature, blood pressure, serum glucose, increase this discrepancy between energy supply and demand. The primary objective of acute neuroprotective and fibrinolytic stroke treatment is to rescue this at-risk penumbral tissue to salvage brain function. Now, when considering the potential risk factors for childhood arterial ischemic stroke, we first of all have to consider arteriopathy or CNS angiitis or vasculitis. It's all different names for the same stuff, and this can be para-infectious following or related to an infection, but it is not infected, but there is no actual infection. Or it can be a primary angiitis of the CNS, and the primary angiitis of the CNS can occur in childhood or adulthood, and that's why we call it here childhood primary angiitis of the CNS. It can also be a transient cerebral arteriopathy, focal cerebral arteriopathy, post-varicella angiopathy. Less commonly, it can be secondary to a secondary CNS vasculitis to a more generalized process, like for example in systemic lupus or inflammatory bowel disease, etc. It can be associated with, it can occur in Takayasu arthritis, post-radiation vasculopathy, reversible cerebral vasoconstriction syndrome, or it can be due to genetic or congenital defects like connective tissue diseases, progeria, fibromuscular dysplasia, etc. Other causes of childhood arteriopathy include direct infections like bacterial meningitis, or viral infections like Japanese encephalitis, Coxsackie viral, Urovirus, etc., or fungal spirochetal infection. All of those infective agents can be associated with arteriopathy or angiitis of the CNS. Dissection of the vessel of arteries like internal carotids or vertebral or other intracranial arteries also can cause ischemic stroke, moya, whether idiopathic or syndromic, and neurofibromatosis, trisomy 21, etc., as well as other rare causes. Cardiac causes as potential risk factors for childhood ischemic stroke include congenital heart disease, and this is a major underlying cause. Whether there is a shunt with right to left shunt, or following complex congenital heart surgery, cardiac catheterization, bacterial endocarditis, etc. All these can be associated with arterial ischemic stroke. Less commonly, it can occur with cardiomyopathy and myocarditis, aortic cavitation, atrial myxoma, valvular diseases or arrhythmias, ECMO, cerebral angiopathy, or embolism as a result that can be air, fat, or amniotic fluid. Potential risk factors for childhood arterial ischemic stroke in association with prothrombotic factors include deficiency of many of the factors involved in the coagulation, like factor V Leiden, antithrombin 3, or deficiency of certain proteins like protein C and protein S, in association with lupus anticoagulants and anticardiolipin antibodies, or in some metabolic disorders like in the methyl tetrahydrofolate reductase deficiency, hyperhomocystinemia, Other factors like plasminogen deficiency, dysfibrinogenemia, sticky platelet syndrome, pregnancy, or purpurea can all be associated with arterial ischemic stroke. Hematological factors as potential risk factors for childhood arterial ischemic stroke include sickle cell disease, iron deficiency anemia, leukemia, thalassemia, thrombocytosis, polycythemia, hemolytic uremic syndrome, etc. Those are less common, and of course, sickle cell disease and iron deficiency anemia are the more common factors. Other factors include drugs like chemotherapy, ergots, less commonly ergots and triptans, methamphetamine, recreational drugs, oral contraceptives. Also, migraine can be a risk factor for arterial ischemic stroke. Inborn errors of metabolism like Fabry's, mitochondrial, and as previously mentioned, homocystinuria. Less commonly, metabolic syndromes with hypertension, diabetes, insulin resistance, and dyslipidemia and atherosclerosis. Also, cigarette smoking and secondhand smoking are considered as risk factors for arterial ischemic stroke in children. Intracranial hemorrhage. Intraparenchymal hemorrhages are most often caused by brain tumors, AV malformation, coagulopathies, including various causes of thrombocytopenia, hemophilia, von Willebrand disease, sickle cell anemia, hypertension, and infections. Intraparenchymal hemorrhages of idiopathic origin are also frequent. Subarachnoid hemorrhages are most commonly caused by intracranial aneurysm, and ruptured aneurysm account for about 10% of intracranial hemorrhages in children, as well as trauma. So what are the signs and symptoms that we expect to see in a child presenting with acute ischemic stroke? Many symptoms can be the presenting manifestation. Focal motor, focal motor deficits, mainly hemiparesis, are the most common presenting manifestation. It can be associated with altered mental status, aphasia, dysarthria, or agnosia, seizures, a headache that can be sudden and severe, visual loss, movement disorder, or cranial nerve dysfunction. Various combinations of these signs and symptoms can be present. However, it's not a must. Any diffuse or non-focal neurological signs and symptoms such as headache, confusion, irritability, and behavioral changes are frequent, especially in young children. So, ischemic stroke should be considered again in any child presenting with acute neurological deficits, not necessarily motor, and this is particularly noticed in the young children. The differential diagnosis of stroke involves the differential diagnosis of the etiology and the differential diagnosis of stroke itself from stroke-like episodes. So the differential diagnosis of the etiology includes the arteriopathy, whether it is primary or secondary, infections, dissection, moya, neurofibromatosis, cardiac disorders, hematological disorders, and inborn errors of metabolism. While stroke-like episode, differentiating stroke from stroke-like episodes includes migraine, seizures and post-ictal status, demyelination and acute cerebellar ataxia, inborn errors of metabolism, hypertensive encephalopathy, channelopathies, hypoglycemia, and watershed hypoxic ischemic encephalopathy. Among the previously mentioned differential diagnoses, the more commonly encountered ones include differentiating between stroke and stroke-like episodes and the etiological differential diagnosis. Between stroke and stroke-like, the more common stroke-like episodes include complex migraine, especially with focal aura or hemiplegic migraine, focal seizures, and focal seizures with post-ictal weakness or TODS paralysis. Regarding the etiological differential diagnosis, it's most important to differentiate between ischemic and hemorrhagic and other focal pathologies. Now we'll talk for some minutes about special cases, like for example neonatal stroke. Like newborn babies are different from children, every disease has its characteristic in the newborn, and so is the ischemic stroke. Hypoperfusion or stroke in general. In neonatal period, hypoperfusion and hypoxic ischemic encephalopathy are common causes of neonatal stroke. However, stroke in the newborn can also be hemorrhagic and can be a combination of ischemic and hemorrhagic. Venous infarcts are also common in the newborns, and they are usually adjacent to the dural sinuses and show hemorrhagic components. During evaluation of the newborn with stroke, we can have positive findings on diffusion-weighted images and MRI, but negative findings on MRE and MR venography. Moyamoya disease. Let's start by a case of a boy, 8 years old, presenting with acute onset left hemiplegia after 10 months of transient alternating hemiplegia related to hyperventilation. The patient had severe motor disability bilaterally with cognitive delays and was still non-verbal. Radiological studies showed a large arterial ischemic stroke of the right frontal lobe, accompanied by additional large vessel and watershed lesions bilaterally. During his follow-up visit, his 15 years old sister mentioned having headaches, and she had radiological evaluation. There were several small ischemic lesions in the periventricular white matter, as you can see at the arrows, but was very good in everyday life and all aspects. She was an honors student and had a normal neurological examination. So both children have moyamoya disease, and their angiogram shows obstruction and narrowing of the carotids and internal carotid arteries with the formation of collaterals, and this is characteristic of moyamoya disease. So what's moyamoya disease? Moyamoya describes the progressive occlusion of cerebral arteries at the circle of Willis. This leads to the formation of abnormal networks of small collateral vessels with a puff of smoke appearance on angiography. The classic pattern involves the distal internal carotid arteries bilaterally. However, unilateral and other vessel involvement have been described. Moyamoya progresses slowly over time, causing accumulating injury and poor neurological outcomes. The important mechanism of moya-moya associated infarction is hypoperfusion with involvement of watershed areas. Typical acute ischemic stroke occurs with artery-to-artery embolism. Moya-moya vasculopathy is a non-inflammatory progressive cerebrovascular occlusive disease that shows slowly progressive stenosis and occlusion of cerebral arteries, especially those surrounding or feeding the circle of Willis. Etiologically speaking, it may be idiopathic or primary, and in this category, some cases have been shown to be transmitted in an autosomal recessive pattern of inheritance. Or it can be secondary in association with other disease states like neurofibromatosis, fibromuscular dysplasia, Marfan syndrome, Down syndrome, radiation vasculitis, infections and post-infectious vasculopathy, congenital heart disease, Fanconi. So many diseases have been associated with moya-moya, and this reflects the nature of the nomenclature of the disease, which is named after the radiological appearance of the vascular pattern as seen in the angio, and as a puff of smoke, and obviously this can result from many causes. In Moya disease, stenosis tends to involve proximal arteries, and it is most frequently identified, and the most frequently identified collaterals are in the lenticulostriate vessels, which are end arteries. Moya is identified at least in 70% of cases during childhood, and in 50% of cases below the age of 10 years. Now we go to the management of the child with stroke, and the aim of management is to maintain cerebral perfusion, oxygenation, and minimize the demand for cerebral blood flow. During the first 15 minutes, we tend to keep the head of the bed flat if the patient is alert, or at 30 degrees if not alert, to avoid the risk of aspiration. Fluids, IV fluids, could be isotonic at a maintenance dose, no dextrose to avoid hyperglycemia, and check blood glucose to maintain euglycemia. Oxygen only if needed to keep saturation more than 95%. Acetaminophen if temperature is about 37. So now that we know our priorities, what shall we do with the patient presenting with a definite stroke, or an infant presenting with possibly non-localizing signs but acute neurological manifestations? We will go hand by hand, taking the history and trying to reach a diagnosis and the anatomical distribution of the neurological deficit together while we are starting our supportive care. So we do physical examination, we hear a full history, physical examination, we monitor the vital signs, and do a neurological examination as well as complete physical examination. Meanwhile, we are giving full supportive care, maintaining respiration, blood pressure, positioning the patient, and maintaining the blood glucose, treating starting treatment for possible infections, seizures, and fever, as well as any possible increased intracranial tension. Then we go to the diagnostic studies. Of course, CT is of great help in diagnosing intracranial hemorrhage or traumas in general, but in the acute ischemic stroke, within the first 12 hours, CT is usually not informative. MRI has a privilege over CT during this phase. So if possible, we can go on with an MRI, MRA, diffusion weighted images, and MRV, whatever is possible and available at that time. If not, at least a CT to start with will help us exclude hemorrhage so that we can start our treatment. Laboratory studies include complete blood picture, blood glucose, CRP, ESR, and all laboratory studies that are relevant to the differential diagnosis. And workup subsequently, workup that is relevant to the possible etiologies like echo, Doppler, coagulation studies, etc. As mentioned in the past slide, radiological evaluation comes top in the evaluation of patients with stroke, and MRI is superior in most instances to CT. However, it is less available, more expensive, and it takes a longer time to perform. MRV is especially important in cases of sickle cell disease, and CT especially in cases of intracranial hemorrhage, and will help exclude intracranial hemorrhage early and rapidly. Neck vessel imaging with by MR or CT angio rather than ultrasound is indicated whenever indicated. Echocardiography and possibly transthoracic to search for a patent foramen ovale, and this is important for source of thrombi. In the laboratory studies, we have to do the thrombophilia studies. As mentioned, MRI plays the most important role in the diagnosis of, in the anatomical diagnosis of stroke. It shows that both gray and white matter involvement. Diffusion weighted images have an important role, and they will reveal hyperintensity in acute infarction soon after the onset of ischemia, with diffusion restriction within 45 minutes. FLAIR will show edema in 6 to 12 hours. T2 weighted images will show edema in 12 to 24 hours, and perfusion studies can show the ischemic penumbra. MRS will show increased lactate in the ischemic or infarcted areas. Significant diffusion weighted lesions have been associated with little clinical recovery, with follow-up scans demonstrating fixed lesions. However, in contrast to adults, pediatric stroke patients with regions of diffusion weighted hyperintensity did not uniformly progress to infarction as determined by serial MRIs. And this suggests that in children, diffusion weighted images can demonstrate tissues that are compromised, but not necessarily to the point of irreversibility. So to sum up the MRI findings, the combination of MRI, diffusion weighted images, diffusion tensor images, perfusion weighted images, MRA, and MRV as clinically indicated offers the best sensitivity for the detection of lesions and determination of its extent and evaluation of the degree of underlying vascular compromise. It is still needed to verify which extent whether resolution of diffusion weighted image lesions corresponds with clinical recovery or persistence of deficits, this actually needs further outcome studies. Next, we come to the treatment that involves neuroprotective therapy and preventive measures. Neuroprotective therapy. It aims at delivering an adequate supply of oxygen and glucose to the ischemic tissues in the penumbra, while reducing neuronal metabolic demand by aggressive control of fever and seizures. How can we reach this? First, we maintain euglycemia because both hyperglycemia and hypoglycemia are associated with poorer neurological outcomes in adult stroke, and it is likely the same for children. Second, maintaining blood pressure between the 50th and the 90th percentile and avoiding blood pressure fluctuation. Third, maintaining normal oxygen saturation, and the role of supplemental oxygen in normoxic patients is controversial, with mixed evidence from adult stroke studies. Therapeutic hypothermia is not indicated. Temperature control to avoid hyperthermia, including aggressive treatment of infection and regular doses of antipyretics, is very important. Aggressive treatment of seizures is mandatory, and to ensure adequate hydration and treatment of anemia are of most important. Measures to reduce increased intracranial pressure should be considered, including adequate sedation, paralysis, manipulation of PCO2, and osmotic therapy such as mannitol. Thrombolytic therapy is not indicated in children. However, extending adult thrombolysis protocols to older adolescents seems possible. Antithrombotic therapies aim to prevent early propagation or re-embolization of initial thrombus, inhibit the formation of new thrombi, and promote early recanalization. Theoretically speaking, antiplatelet agents should be used in arteriopathies, while antithrombotic agents should be used in all other cases. However, there is no fixed protocol. Starting treatment with low molecular weight heparin at a dose of 1 mg per kg given every 12 hours is indicated in ischemic stroke. This may prevent further strokes, but wouldn't help this one to improve. However, the risk of hemorrhagic transformation of ischemic stroke is much less after the first 48 hours. Long-term treatment with warfarin is an option for secondary stroke prevention, and aspirin at doses of 3 to 5 mg per kg per day is another option. Aspirin. For all older children with ischemic stroke, except kids with sickle cell disease, aspirin is indicated in a typical dose of 3 to 5 mg per kg per day. The risk of Ray's syndrome is extremely low. Still, it is strongly recommended to annually receive the flu vaccine, and some will hold aspirin with fever or flu-like symptoms to avoid the risk of Ray's syndrome. Sickle cell disease treatment is transfusion, possibly exchange transfusion, and the treatment of hemorrhagic stroke is directed towards cause and symptomatic treatment and possibly surgical management. Treatment of moya is more complex. Antiplatelet therapy with acetyl salicylic acid is often employed and is likely safe. Carbonic anhydrase inhibitors like acetazolamide may shift acid-base balance to favor vasodilatation. However, this should be judiciously done in severely affected children because of disturbances in autoregulation. In children with moya and hypertension, the use of hypertensive should be very carefully done, because even small decreases in cerebral perfusion can lead to infarctions. Finally, surgical bypass procedures are highly successful at improving cerebral perfusion in children with moya moya. Direct procedures connecting extracranial blood vessels such as the superficial temporal artery to distal intracerebral vessels, usually with middle cerebral artery, are the usual procedures. So what are some take-home points? First, potential causes of childhood stroke are diverse and do differ in many cases from those seen in adults. The diagnosis of acute ischemic stroke is particularly challenging in the young child because of a high number of stroke mimics and vague presentations in infants. Reperfusion strategies, including intravenous tissue type plasminogen activator and endovascular thrombectomy, have been used in adolescents but remain unproven in children. So to sum up, stroke. The most common clinical presentation in order of frequency are focal motor deficits, headache, seizures, aphasia, and encephalopathy. The most common identifiable etiology in order of frequency are heart diseases, vasculopathy, sickle cell disease, and hyperprothrombotic states. Accordingly, we can say that the most common single etiology by far is vasculopathy, and the most important diagnostic tool is MRA or CT angio, and keeping in mind that usually we get affection of the anterior circulation more commonly than the posterior, the left side more common than the right side, and diffusion weighted images shows restricted diffusion within the first 45 minutes of the onset of stroke. Finally, the most important factor in the management is time. This is very important, and that's why we, maybe in the first or second slide, I mentioned that it is very important to consider stroke in any child, especially if infant presenting with an abnormal neurological finding, not necessarily that you can identify focal motor deficits, and this has to be high in the list and should be considered very early because the outcome depends on early management. Finally, I'll take a couple of minutes to talk about childhood primary CNS vasculitis or angiitis. The diagnosis of primary angiitis of the CNS requires the following. 1. An acquired and otherwise unexplained neurological or psychiatric deficit. 2. Classic angiographic or histopathological features of angiitis within the central nervous system, and the absence of another systemic disorder to explain these features. Inflammatory immune-mediated vasculitis is the most common cause of stroke in childhood beyond the neonatal period. The classification is largely based on neurological findings at diagnosis and follow-up imaging. The most common cerebral arteriopathy causing arterial ischemic stroke in childhood is non-progressive or transient cerebral arteriopathy. Less commonly, childhood primary angiitis of the CNS is progressive. Patients with CNS vasculitis can present with seizures and intractable seizure status, headaches, Stroke or other severe focal neurological deficits, including impaired vision, speech deficits, or movement disorder. Severe diffuse deficits such as memory difficulties, cognitive dysfunction, or behavioral problems, school deterioration, and psychiatric symptoms such as hallucination can also be a presentation. Fluctuating level of consciousness and myelitis can be of the presenting manifestations of CNS angiitis in childhood. Assessment by an ophthalmologist can be of great help to identify retinal arthritis and signs of systemic or local inflammatory. Primary childhood angiitis of the CNS can involve large vessels or small vessels. Large vessel affection can be identified by angiography. In non-progressive childhood, primary angiitis of the CNS of the large vessel type is more common in boys than in girls, and clinically it usually presents with unilateral stroke. Inflammatory markers in serum and the CSF are usually normal, and MRI shows unilateral fluid attenuation inversion recovery in T2 diffusion, in T2, and diffusion restricted lesions as well. Angiography shows unilateral proximal vessel stenosis and gadolinium wall enhancement. Brain biopsy in these cases is not needed. On the other hand, in angiography, negative small vessel childhood primary angiitis of the CNS, girls are more commonly affected than boys. The clinical presentation involves seizures, focal and or diffuse neurological deficits, and psychiatric symptoms. Inflammatory markers are commonly raised both in serum and CSF. MRI shows white and or gray matter fluid attenuation inversion recovery on T2 and not restricted to a certain anatomical vascular territory. Angiography is normal, and that's why in those cases we need to do a brain biopsy to confirm the diagnosis, and this will show intramural and perivascular lymphocytic infiltration. Finally, this slide shows the protocol for a treatment of primary CNS angiitis of childhood, and it is based on immunomodulating treatments, should be continued for about 3 months. Thank you.